All right, let's dive into a classic clinical puzzle, one that you'll definitely see in practice. You have a patient with high blood pressure, but when you look at their labs, their potassium is weirdly low. Now, that is no coincidence. Those two things are directly connected, and we're about to figure out exactly how. So, picture this. Your patient's blood pressure is 160 over 100, and their potassium comes back at 2.8. Yikes. Now, your first instinct might be to just give them some potassium, right? But hold on. The real question, the one that gets you to the right diagnosis, is why? Why are these two things happening at the same time? Figuring that out, well, that changes everything. So here's our game plan. We're going to start by meeting the two key players in this whole drama. Then, we'll work through 3 different case files, each with its own unique lab pattern. And finally, we'll put it all together into a diagnostic blueprint that you can take with you. Let's get started. To solve this entire mystery, you really only need to understand 2 hormones, renin and aldosterone. You can think of them as the master regulators of your body's salt, water, and potassium balance. Honestly, their relationship is the key to unlocking this whole thing. Okay, so here's the fundamental trade-off happening inside the kidney. Aldosterone's main job is to tell the kidney to grab sodium and pull it back into the body. But as all that positive sodium leaves the urine, it creates this powerful negative electrical charge. Well, the body has to balance that charge, so it's forced to kick out another positive ion, and that ion is potassium. The rule is simple. The more sodium you save, the more potassium you lose. And the hormone that kicks off this whole chain reaction, that's renin. Their levels literally tell you the whole story. All right, let's open up our first case file. This is the most common pattern you're going to encounter, what we're calling the aldosterone overload. The lab results are in, and they are painting a very clear picture. Renin is low. It's suppressed. The body is basically whispering, hey, please stop. But look at aldosterone. It's sky high. It's completely ignoring the command. So let's think about this. If the boss, renin, is telling everyone to take it easy, but the worker, aldosterone, is just shouting and going wild, where do you think the problem is? What's your diagnosis?
And you got it. The diagnosis is primary hyperaldosteronism. The problem is coming directly from the adrenal gland itself. It's gone rogue, churning out aldosterone all on its own, totally ignoring those low renin signals. This is usually caused by a small, benign tumor, an adenoma, or just some overgrowth of the adrenal tissue.
And here's exactly how that plays out. That rogue aldosterone just cranks open way too many sodium channels in the kidney. Sodium rushes back into the body, water follows it, and boom, blood pressure skyrockets. And just like we talked about, all that sodium reabsorption forces potassium out, giving you that classic 1-2 punch of high blood pressure and low potassium.
Now for our second case. This one's a little bit more of a head scratcher, a little counterintuitive. We call this scenario the aldosterone imposters.
Okay, look closely at these labs. The patient still has high blood pressure, still has low potassium, but this time, both renin and aldosterone are low. The entire system is shut down. That is a massive clue.
So this really makes you wonder, if aldosterone isn't the culprit, what on earth is acting like it is? What could be hijacking the system and forcing the kidney to hold on to sodium and dump potassium, even while the body is trying to slam on the brakes by suppressing both renin and aldosterone?
Well, the first imposter is Little syndrome. It's a rare genetic condition where the problem isn't the hormone signal, it's the channel itself. A mutation basically leaves the sodium channel permanently stuck in the on position, kind of like a light switch that's broken. It's just pulling in sodium 24/7, no matter what aldosterone is doing. The second possibility is a mouthful, apparent mineralocorticoid excess. So think of the aldosterone receptor as a lock, and aldosterone is the specific key. Well, your body has tons of another hormone, cortisol, that looks a lot like that key. Normally, a special enzyme stands guard and stops cortisol from getting into the lock. But if that enzyme gets blocked, and the classic culprit is a compound in black licorice, then cortisol can just flood the system and start unlocking all those aldosterone receptors, tricking the kidney. So it's actually a pretty simple way to think about it. With Little syndrome, the hardware is broken. The channel is physically stuck open. With apparent mineralocorticoid access, the software is being tricked. The wrong hormone is opening the lock. But either way, the end result is exactly the same. And you can see that shared pathway right here. One way or another, the sodium channel gets overactivated. That leads to sodium and water retention, which causes hypertension. That, in turn, creates that electrical pull that drives potassium loss.
And the whole time, the body sees all this salt and water and tries to fix it by shutting down both renin and aldosterone. But it's a completely futile effort because the problem is downstream, beyond their control. Okay, time for our final case, which has a completely different signature. Welcome to the run-in, run-away. This time, the labs show that both renin and aldosterone are high. The whole system is floored, just completely in overdrive. This tells you right away the problem isn't in the adrenal gland. It's got to be upstream at the source of the renin, which is the kidney. So think about it. What could possibly make the kidney release massive amounts of renin, even when the patient's blood pressure is already sky high? What could fool the kidney into thinking it's not getting enough blood? The answer is secondary hyperaldosteronism. The high aldosterone here is a secondary response to the crazy high renin. The most common cause by far is renal artery stenosis, a blockage in the artery that feeds the kidney. The kidney senses low blood flow locally and just starts screaming for more pressure by dumping out renin. A much, much rarer cause would be a renin-secreting tumor. And this just traces that whole cascade for you. The kidney gets tricked into thinking the body's pressure is low, so it unleashes a flood of renin. Renin kicks the whole system into high gear, which leads to high aldosterone. And from there on out, the story is exactly the same. Aldosterone hits the kidney, causes sodium retention and hypertension, which then drives potassium loss and hypokalemia. So we've walked through the 3 major pathways. Now let's pull all of this together into a single, powerful tool that you can actually use. In this table right here, this is the key takeaway. This is your blueprint. Anytime you have a patient with hypertension and hypokalemia, just check their renin and aldosterone, and it will drop them into one of these 3 buckets. If renin is low and aldo is high, you're thinking primary hyperaldosteronism. If they're both low, think about one of those imposters like Little's or licorice. And if they're both high, you need to go hunting for a cause of secondary hyperaldosteronism like renal artery stenosis. And just like that, the puzzle is solved. With just 2 lab values, you've gone from a confusing clinical picture to a specific diagnosis. You figured out the why. So the only question left is, now that you know the cause, what are you going to do about it?